Welcome, everybody, to the 2021 CJD Foundation Virtual Conference. We wish we were together with you in person, but we are so glad that you can join us for this virtual event. We first want to thank our partners, the Centers for Disease Control and Prevention and the National Prion Disease Pathology Surveillance Center. We also thank our sponsors, Ionis Pharmaceuticals and Charles River Labs. Just a reminder, you can submit questions throughout the presentation, and we'll answer as many of them as we can at the end. We're pleased to present tonight Dr. Ryan Maddox, epidemiologist at the CDC. We're so grateful for the work that he and his colleagues do in surveilling prion disease. And we're grateful for the time he spends updating us and answering our questions. So welcome to Dr. Ryan Maddox.
So thank you for this opportunity to talk about the CDC and our activities related to prion disease. I always appreciate this opportunity, and maybe next year we can do it in person. You know, we'll certainly hope for that. But I'm glad we have the technology to do it in this format this year. So why don't we jump right into it? For those of you who don't know, CDC is a part of the Department of Health and Human Services. We're the nation's leading public health agency, and we have a mission to work 24/7 to protect America from health, safety, and security threats, both foreign and in the US. And of course, a big part of that mission over the past year or so has been COVID-19. Perhaps you've heard of it. That's kept a lot of us busy, but we do have a lot of other activities going on. In fact, CDC employs over 14,000 people in 170 different occupations. So it's a very large enterprise. It's headquartered in Atlanta, but there are locations in other states as well as other countries. And so that's just kind of a snapshot of the CDC. And it is the Centers for Disease Control, not the center. And our particular center is the National Center for Emerging and Zoonotic Infectious Diseases. And within that, we are in what I think is the most important sounding division in all of CDC, the division of high consequence pathogens and pathology. And as a small part of that division, we are in the Prion and Public Health Office. We're just a small group, but we are tasked with national surveillance for human prion diseases. And that surveillance includes things like monitoring this disease in the population. For example, what kind of rates are we talking about? Are there changes over time? Is there anything new going on with new prion diseases? And also, we just want to gain knowledge about these diseases that can help hopefully lead to prevention or reduction in rates in the future. And our best picture of surveillance is obtained through two primary mechanisms, and that's through death certificate data and data from the National Prion Disease Pathology Surveillance Center. CDC helps fund that center. We have a very strong collaboration. They share their data from their specimen testing with us, and we use that to match with the death certificate data to get the best picture, like I said, of what's going on in this country in any given year. So this death certificate data I mentioned comes from the National Center for Health Statistics. That's another CDC center. Why is death certificate data good? Well, it's routinely obtained and cost effective. And as you are all unfortunately very aware, these diseases are always fatal. So the death certificate is a very efficient way of determining who is dying of this disease each year. And I know a big concern is, does CJD always end up on the death certificate? We have something called a literal text search, which allows us to see if prion disease or GSS or CJD spelled incorrectly, Jakob-Creutzfeldt instead of Creutzfeldt-Jakob, any one of those combinations will be picked up if it's written on the death certificate. So not perfect, but a very good way of getting a snapshot of the CJD picture. And then we take the results of specimen testing from the National Prion Disease Pathology Surveillance Center, and we match that to the death certificate data. So if we find a case that died, for example, in 2018, and we can't find that particular person in the death certificate data, we'll add them. At the same time, if they are in the Prion Center data with a negative autopsy, we'll remove them if their name is in the death certificate data. So it's a process of adding and subtracting to get the best picture of the incidence of prion disease. And to give you an idea of the numbers we're talking about, from 2003 to 2018, there were 6,781 people that we identified as having died of prion disease during that time period. And that comes out to a rate of about 1.2 per million per year. Slightly higher among men, 1.3 per million, compared to females, where it's 1.1 per million. And a lot higher among white versus Black people who died of this disease, 1.3 versus 0.6 per million. So there are gender and racial differences in the incidence. And also within age itself. You probably are aware that primarily these diseases affect the older population. And so when you look at those greater than or equal to 65 years of age, it actually jumps up to 6 cases per million per year. But another way of looking at this is there's approximately 1 CJD death for every 6,000 deaths overall in the US each year. So obviously that statistic sounds a little different than that 1.2 per million statistic. So there are different ways of looking at the occurrence of this disease. And just to give you an idea of how many cases we're adding and subtracting during this matching process, from 2003 to 2018, we were adding between 6% and 18% of the cases were based on this positive results from the Prion Center that we added to the death certificate data. At the same time, we're removing between 2% and 6% of cases with a negative test result who still had a death certificate diagnosis of CJD or other prion disease. We hope that this is going to get better as we go along. And a lot of that is due to the optimism we have about a relatively new test called the RT Quick test. And the Prion Center really jumped into this around 2015, 2016. And we are currently evaluating the 2019 data now. The death certificate data runs a little bit behind. So we are still working on matching that 2019 data. Our hope is that we're not going to have to add as many Prion Center cases this year because of that RT Quick test, hopefully identifying more of these cases prior to autopsy so that death certificate is more accurate. And so hopefully we'll be able to see if that hypothesis bears out in the near future. Part of the CDC case definition for probable CJD is any neuropsychiatric illness plus a positive RT Quick. So that would be why we'd expect more cases to be diagnosed as CJD prior to death, instead of having to wait for those autopsy results. So I mentioned 2019 data and how we're still working on it, but this gives you a little bit of an idea about where we are at this point. In 2017, we had 542 total cases that we identified in the country. 2018, it's 503. 2019, we're already at 550, and we haven't added the Prion Center cases yet. So this will be a record year in terms of numbers. I'm not completely concerned about that. For one thing, this is, like I said, a disease primarily of the older population. So America has an aging population. Every year, there are more people in that upper age bracket. And so we're going to expect more prion disease cases as a result of that. We'll see if we end up adding 42 cases or 32 cases or less than that this year. Like I said, our hope is that we're not going to have to add as many cases based on those RT Quick test results. And just to help get a picture of what I'm talking about here, this graph goes up to 2018. 2019, that bar is going to be higher. Like I said, we're already at 550 cases based on our death certificate data. And we'll be adding at least some cases from the Prion Center data to that. But this provides a nice way of seeing how the disease has changed over time. Again, we focus more on the rate. So this is raw numbers of cases each year. If you look at the rate, it's been rather steady 1.2 per million roughly across that time span. So something that I thought I'd focus on this year are young cases of prion disease. And I define young as my age or younger, but the way that CDC, or at least the office, defines young case is less than 30 years of age. So when we talk about young CJD, we're focused on this less than 30-year category. And you can see how rare it is just by looking at the numbers here. From 2003 to 2020, there were only 18 cases that we had detected in this country. And so extremely rare. Only 6 of those 18 cases were sporadic forms of the disease. 3 were sporadic CJD and 3 were sporadic fatal insomnia. So if you focus only on sporadic CJD in this age group, that comes out to an incidence of 1.2 per billion per year. So you think of CJD as a 1 in a million disease, CJD less than 30 years of age, we're talking about a 1 per billion disease. So extremely rare. I mentioned 18 cases, 6 sporadic. The remaining 12 could be broken down, with most of those being familial, a couple being variant CJD, and one of them being iatrogenic. Interestingly, we're looking at 2019 data. One of the things we focus on first is this young category. There were 3 cases less than 30 in 2019. Usually we see no cases or 1 case. So that was kind of a blip in our data. And we certainly were interested in that. And we did take a closer look, and I can talk about that a little bit more in a minute. So this is a nice color-coded way of looking at the last 6 years of young cases of prion disease. The red cases are genetic, the blue cases are sporadic, and there are no cases over this time period that were acquired or iatrogenic prion disease. So you see that lots of red cases, GSS, FFI, there's a familial CJD case in there. And so that makes up the majority. We did have 4 sporadic cases. 2 are sporadic fatal insomnia, 2 are sporadic CJD. So we looked at these 2019 cases where there were 3, and right away, one of them was familial. And so these cases happened, of course. One was SFI, and we took a closer look at that sporadic case. We've actually, in collaboration with the Prion Center, submitted this case to a journal as a case report, just to highlight the fact that sporadic cases can happen in this age group. We didn't find any risk factors to suggest that something other than sporadic was at play here. And so, like I said, most of these cases can be attributed to the presence of a genetic mutation or other risk factors. Some of those risk factors would be things like contaminated human growth hormone, exposure to bovine spongiform encephalopathy, et cetera. Now, why don't we see these acquired cases in this young age group, whereas we used to? And that's because most of those acquired cases were exposed years ago, in the 1970s, early 1980s. So that group of people that were exposed are well over 30 years of age now. We still see a case from time to time due to human growth hormone. However, it wouldn't be in that under 30 age group. But back in the day, when these cases first started popping up, they were really important initial signals that highlighted that something strange was going on. And so that's why we recommend continued identification and full workup of these cases in this age group, because they could be a signal of a new exposure, perhaps. We still use neuropathology as our gold standard. And of course, just like young cases are a sentinel, neuropathology can be a sentinel. It can highlight a unique or possibly emerging prion disease case. Different in the way the brain tissue looks when they analyze the specimen could highlight that something unusual is going on. So certainly we encourage autopsy when that can be performed. RT-QuIC is an outstanding test, but it still is compared to results with that gold standard brain tissue analysis. And work by the Prion Center highlighted the fact that the diagnostic sensitivity of this test is lower for certain types of prion disease, such as FFI, GSS, SFI, VPSPR, and the VV1 and MM2 subtypes of sporadic CJD. And obviously, that's a lot of letters I just threw at you, but the bottom line is the test is great, but in certain categories, it's not always perfect. And you see that I mentioned VV1 sporadic CJD in there. And in fact, some of our young cases are VV1. And so again, that highlights the importance of autopsy for those cases because they may have a negative RT-QuIC, but at the same time may actually have prion disease. And so, as I said earlier, those neuropathology results are used to adjust the death certificate data, which gives us the most accurate calculations we can get for the incidence. And I say it every year, I'll say it again, the bottom bullet here, we don't capture every single CJD case. We do the best we can to capture most of them. I think the surveillance is pretty good. The fact that we use several mechanisms, not just the death certificate data, not just the Prion Disease Pathology Surveillance Center data, but also reports from public health departments, medical personnel, family members, the public, the media. You know, when we hear about a case, we try our best to verify it and include it as part of our surveillance system. And it comes up year to year. Can death certificates be amended if they do have an incorrect diagnosis? They can. The process varies from state to state. So you'd have to check with your own state public health department in terms of the appropriate process for your state in terms of how to do that. That's the strength of the RT-QuIC, that hopefully, again, we'll have the correct diagnosis at the time of death. In the past, you had to wait for those autopsy results to come in, perhaps. So hopefully this won't be as much of an issue going forward. We do fund several states for enhanced surveillance for prion disease. CJD is actually reportable in some degree in almost all states, which helps. It doesn't necessarily translate always into more accurate surveillance because if a case is misdiagnosed, it'll still be misdiagnosed regardless of whether it has to be reported or not. But we hope that where there is state involvement, there will lead to interest in the disease and better reporting in general. And so we continue to work closely with the states, as does the Prion Center, to enhance surveillance for prion disease. I'll mention variant CJD briefly. Of course, this is the human form of bovine spongiform encephalopathy or mad cow disease. Still holding steady at 232 cases worldwide, most of those in the United Kingdom. The most recent was a couple years ago in France. In fact, that was a lab exposure that happened around 2010, I believe, where someone was working with a BSE sample and accidentally, I think, injected herself as she was working with a specimen. So very unfortunate situation. So these diseases still happen. In that particular case, it wasn't from consumption, but rather, like I said, exposure in the laboratory. Only 4 cases in this country, 2 in Canada, and the good news is that none are believed to have been exposed to the infectious agent in this country or in North America. So shifting gears a little bit, I'll talk about tissue donation and organ donation and blood donation and things like that. And it remains the case that human cells, tissue, corneas, things of that nature, not be donated if you've been diagnosed with any form of CJD or if you have a history of the disease in the blood relative. There's also additional restrictions if you spent a certain amount of time in the United Kingdom or in Europe, and there's time periods there. What has changed recently, well, let me talk about organ donation first. Organ donation is not regulated by the FDA. So there's no absolute exclusions. And so there's basically a risk-benefit analysis that's performed by medical staff in terms of whether they're going to use that organ or not. So you can donate, but it may or may not be used. So back to what has changed. Last year in April, there was an update to blood donation recommendations. So there's still a certain group of people that are ineligible to donate. For example, people with history of a transfusion in the United Kingdom, France, or Ireland from 1980 to the present. People that spent 3 months or more from 1980 to 1996 in the United Kingdom, or 5 years or more cumulatively in France or Ireland during a certain time period. And of course, people diagnosed specifically with prion diseases or with a blood relative diagnosed with genetic CJD. So there's still a group of people that cannot donate. However, they updated the guidance in a few key ways. One is the recommendation to defer former or current U.S. military personnel and people who resided at U.S. military bases. Those are no longer deferred. People who spent 5 years or more in Europe from 1980 to the present, excluding what I mentioned earlier, and they no longer recommend questioning donors regarding blood relatives with genetic CJD. So if you had a blood relative with CJD who was not diagnosed with the genetic form of the disease, you would be allowed to donate now. Now, there's a little bit of a process here. If you were previously deferred, it may not be as easy as just walking into your donation center and saying, I'm okay to donate now. I think the rules are going to be a little different from place to place. From what I've seen, in a lot of cases, you have to actually call the center to have your name removed from that deferral list. You can't fill out an online form or just go in, like I said. And I think they're still working on that if you've been previously deferred, how you become eligible once again. Now, if you've never been deferred, if this is something new, then you can probably just walk in and answer the questions and donate. So the process will probably differ from place to place. Final notes about blood. The good news is CJD has not been shown to be transmissible through the blood. A lot of these precautions are just a better safe than sorry approach. Study by American Red Cross and CDC from a few years ago concluded that there's still no evidence of CJD transfusion transmission. It's a theoretical risk. Similarly, the United Kingdom National CJD Research and Surveillance Unit in the same year said the balance of evidence indicates that if sporadic CJD is transmitted by blood, it must be a rare event if it happens at all. So that's the good news. However, variant CJD, again, what's been linked to bovine spongiform encephalopathy, has been transmitted through blood in a few cases. So it is possible, at least for that form of prion disease. We often get a lot of questions about funeral homes. Embalming the bodies of CJD patients who have been autopsied can be safely performed. We can't force a funeral home to do this, to accept the body. We always stress education to funeral directors, and I know that some of you have been active in that education process, as well as some of the states that we fund for enhanced surveillance. They go out to the funeral homes and try to tell them certain ways where they can be safe and provide these services. We actually have information on our website at CDC that can be helpful to funeral and crematory practitioners. And one quote that we have there sums it up very well, I think, and that is, there are no special interment, entombment, inurement, or cremation requirements for patients with CJD. Interment of bodies in closed caskets does not present a significant risk of environmental contamination, and cremated remains can be considered sterile as the infectious agent does not survive incineration range temperatures. So the bottom line is we consider this to be safe if regular precautions are taken. And again, those are outlined on the website. But at the same time, some funeral homes still won't be willing to necessarily go along with that. I'm going to talk a little bit about chronic wasting disease, since that's kind of the prion disease of the moment in terms of the animals. This is largely a North American problem. However, it's been recently reported in Norway, Finland, and Sweden. This is a prion disease of cervids, which includes things like white-tailed deer, mule deer, elk, moose, reindeer. It can be highly transmissible within these populations. And we're up to 25 states, 2 Canadian provinces where the disease has been found in free-ranging animals. And so that's kind of a recent update there. You see number 25, the good old state of Ohio. That's where the arrow is pointing there, became the 25th state. So half the US states now have found this disease. in their wild deer or elk populations. And I expect that number to continue to climb as more states, more counties identify the disease. So the media was very attracted to CWD a couple years ago. Before COVID-19, there was zombie deer disease. That's what they unfortunately referred to this disease as. It got a lot of attention. The good news here is that to date, there is no strong epidemiologic evidence for the occurrence of this disease in people. And of course, that's our biggest concern from the human standpoint at CDC. Why are we concerned? Well, like I said, there's no strong evidence for the occurrence of CWD in people, but there's three things that want us to keep an eye on what's going on. For one thing, as that map showed, CWD is being found in more areas. Ohio was the 25th state, but almost all the states have just found this disease in the last 2 decades. Prior to 2000, this was only found in Colorado and Wyoming. So 23 more states since then. And so with this disease in more areas, there's increased opportunities for human exposure. In addition, an animal prion disease has caused disease in humans before, BSE of cattle, of course, causing variant CJD in humans. And some animal studies suggest potential for transmission to humans. And of course, those are animal models, but certainly is something worth paying attention to. So if we saw a young prion disease case with a history of successful hunting in a CWD endemic area, along with an absence of CJD risk factors, that would be a big red flag. I really wanted to include a fancy graphic on this year's presentation. So here it is. That's my big fancy graphic for the year. Of course, the one thing to consider is that a lot of people in this country hunt. A lot of the people in this country consume venison. So even if we did find a young case with a history of venison exposure, that still wouldn't necessarily 100% guarantee that there's transmission. In fact, that young VV1 case from 2019 had consumed deer a couple times. However, we took a close look at that and found that the deer wasn't obtained from an area where CW had been identified at the time. And so we were happy that the Prion Center had been able to look into that and provide us with that assurance. Like COVID, CWD presents a bit of a challenge because of asymptomatic spread. And so that's something else we have to pay attention to. If a hunter harvests a deer that doesn't seem to be showing symptoms, that doesn't mean that the deer is free of the disease. And so we encourage people who hunt in areas where the disease has been found to consider testing of that animal to see if it's positive for the disease. We have several studies going on to take a closer look at whether transmission occurs. I mentioned Wyoming and Colorado had this disease early on. And so we're following up people who've hunted in those 2 states to see if they are dying of prion disease at a higher rate than the general population. We're looking at people who consume venison from CWD positive deer in Wisconsin. And fortunately, so far, we have not found any matches between those people who consume venison and people in the National Multiple Cause of Death data or the Prion Center specimen data. So no matches is good news. We don't want to find any of these individuals who consume CWD positive deer showing up with the prion disease. Finally, we're looking at highly CWD endemic states compared to other states to see if there's large differences in terms of the rate of human prion disease mortality. Final thoughts, these diseases are obviously unique and present diagnostic and public health challenges as a result of that. Our activities at CDC include conducting surveillance through various methods to best capture the majority of cases. We look at cases of interest, working closely with affected states, and of course, working with the National Prion Disease Pathology Surveillance Center, the CJD Foundation, and medical and public health personnel. We try to provide advice when possible on prion disease-related issues. Finally, improvements in pre-mortem diagnostic testing like RT-Quick will hopefully benefit those surveillance efforts, but we continue to encourage autopsy. You're aware of these resources, I hope, at this point, the CJD Foundation, of course, the CDC, and the National Prion Disease Pathology Surveillance Center. These are some of the people that I work with and really appreciate the collaboration, of course, with the CJD Foundation, the Prion Center, and the state and local public health departments.
All right, so now we're moving on to our live question and answer session. Dr. Maddox, excellent job as always. A very understandable overview of prion disease and epidemiology in the US. Before we open it up to some of the questions that were submitted, I understand you want to touch on just some finer points of the discussion.
Yes, thank you, Brian, and hello everyone from Atlanta. I hope you're doing well this evening. There were a couple quick comments I wanted to make before we get to the questions, and it may have been something that was on your mind as you watched the presentation. The first thing is I just wanted to clarify a part of my presentation where I referred to VV cases. There's a variation at codon 129 of the human prion protein gene. So someone can actually have 2 methionines, 2 valines, or 1 methionine and 1 valine. So that would be referred to as a person with MM or MV or VV. So whether someone is MM, MV, or VV can actually play a role in how susceptible they are to prion disease. It can also show how the illness presents and progresses. And so I'm sorry if I wasn't clear about that during my presentation and I just kind of spewed a bunch of letters at you, but that's what I mean when I say that case was VV or MM. Second thing I wanted to touch on briefly, some of you may have heard through various channels about a situation in New Brunswick, Canada, where there were early indications that maybe a prion disease was involved in this strange neurologic disease outbreak that was going on there. I believe 40-something people were reported as part of this outbreak. And like I said, prion disease was tossed around as a possibility. As far as we're concerned, this is a non-prion disease issue. We've received word that of the 6 cases where they've done an analysis of the brain tissue, no evidence of prion disease was found. In fact, of those 6 cases, I think they actually identified 6 different diseases. So it's a little unclear whether this is really a true outbreak even based on those diagnoses. So if you hear about something weird prion-related going on up north, we don't believe this is a prion disease issue. So back over to you, Brian.
Thank you for clarifying that. I mean, I think this is a struggle that unfortunately the families have noted firsthand, and that is that prion disease can look like a lot of different diseases, right? So it's difficult to diagnose, but often we see the other way around where a different disease is actually misdiagnosed as a prion disease. And I guess what you're saying is that's kind of the situation in the New Brunswick cases. It
is, and it's another example of autopsy saving the day, so to speak, where it could look like a prion disease at first, but really in analyzing that brain tissue can tell you what's really going on. Right. So not to hit you with all the controversial questions from the get-go, but another very commonly asked question that we get at the Prion Center under the foundation gets this question a lot is there any association with COVID-19 and prion disease? Is that to explain for the increase in incidence that you're seeing and or increase in cases, I should say, that you're seeing in 2019? Right. So as far as we know, COVID-19 really didn't hit the scene until late in 2019. I saw a report today that they believe maybe it was circulating in the United States sometime late 2019 or thereabouts. But realistically, there's no biological explanation that I can think of that would relate prion disease to COVID. And that goes for the vaccine as well. We've received the question several times where someone has received the vaccine and unfortunately come down with prion disease symptoms shortly afterwards, maybe a few days, maybe a few weeks. But the 2 messages that I give in these situations, one is, again, the biological plausibility just isn't there. And 2, the fact is over 85% of the older population in this country has received the vaccine now. And unfortunately, some of that older population is going to be diagnosed with prion disease this year. So the odds are in favor of there being onset of prion disease in some individuals who have recently received the vaccine. So no connection that I'm aware of, and really I consider it, like the New Brunswick case, to not really be a prion issue.
We do get a lot of questions about, so-and-so received a dose of the vaccine, and then, later that week, they started developing symptoms of CJD. And of course, at least for the majority of vaccines, these are dual dose vaccines. I guess, is there a statistical likelihood that you would expect a certain number of people would develop sporadic CJD after a dose of the vaccine just by pure chance alone?
Yes, I don't have an exact number to give you, unfortunately, but certainly there would be a number of individuals that would come down with sporadic CJD symptoms within a certain time period after that dose. And like I said, I don't have a hard number to give you, but it wouldn't be out of the blue or unusual to see that occur.
So I think oftentimes, Ryan, in your talks, you talk about the epidemiologic aspects of the disease. And, one thing I would hope that you would touch on a little bit here is just the value of statistics in these rare diseases and how you evaluate them, and how statistics in such a rare disease may be different than a more common disease, let me say Alzheimer's disease. And thank goodness we have people like yourselves that have this expertise. But can you talk a bit about the statistical aspects of these rare diseases and how you use those?
Sure. Yeah, I can give you a couple examples. One thing that I touched on in my presentation was you can't just look at the numbers. What's really important with a disease like this is the rate. If you're looking at a disease that primarily attacks the older population and you have an aging population in your country, you're going to see more cases as the years progress. And if you don't pay attention to statistics, you can look at that and say, what's going on? Why are there all these new cases? When in fact, the rate has been fairly constant, looking back over the last decade, holding steady between 1 to 1.5. There hasn't been this huge increase or fluctuation. So looking at that from more of a statistical standpoint is, I think, very helpful. The other thing that I think is important to look at is the different ways to look at the statistics. And then again, I touched on this briefly during my presentation, but we throw out that number all the time, 1 per million, 1.2 per million. And it makes it sound like this is such a rare disease. And people say, well, wait a minute, I know so-and-so at my church and so-and-so at the synagogue, or so-and-so, 2 houses down from me had this disease. So how is it that rare? And so you have to realize that's 1 per million per year. And also the fact that if you look at all the deaths in the country each year, how many of those are prion related, that number becomes something like 1 in 6,000. So suddenly doesn't seem as rare as it initially sounds. And so I think you just have to look at the exact numbers and exact rates you're looking at to get an appreciation of what's going on.
Those are good points. There may be other factors you think that affect quote unquote clusters of cases. So for example, I moved to Ohio in 2011, and I've treated 5 cases of CJD that live within a 10-mile radius of my home. So, one might think of that as a cluster, but from an epidemiologic standpoint, what kind of things do you look at to kind of investigate a cluster of that sort?
Yeah, that's a good question. And we do see these clusters, or so-called clusters, from time to time. And when we take a closer look, inevitably, the cluster kind of falls apart. And what I mean there is, say we're looking at Ohio and there's 5 cases reported to us of CJD. And so we take a closer look, and it turns out that one of those cases may have had a genetic mutation. So we can't attribute that to any kind of exposure other than the fact that this person has a family history of the disease and unfortunately came down with that. Another one of those cases, for example, may have recently moved into the area. So are we really seeing 5 true cases for this particular location? And third, misdiagnoses do happen. And this happens a lot when we look at these clusters in greater detail is it turns out that one of the CJD cases is not CJD at all. It's Alzheimer's or Pick's disease or one of any number of other dementias that were simply classified as prion disease. And you could bring the New Brunswick situation back into this, where you see all these neurologic diseases and you have one neurologist that's looking at all these and making a determination about what's going on. And sometimes those diagnoses aren't correct. So it's really important to take a look at these clusters and really get a better idea of what's going on. And like I said, when we do that, inevitably these clusters disappear. And one other thing I'll add is if they don't disappear, there is such a thing as coincidence. When you're dealing with diseases of this nature, we like to look at it in a national sense because it kind of smooths things out over time. If you look at a small area with a rare disease, you might see a number of cases one year, and then you may go 3 or 4 years with nothing at all. So it kind of depends on how wide of an area you look at, but you are going to see fluctuations in the data like that.
One of the questions that we had is referring to the incidence number, the 1 to 2 per million per year. Does that include all cases of prion disease? Does it just include sporadic? Does it include genetic? What actually is that population you're looking at?
Right. And I can tell you that when we come up with that number, we include everybody. So other countries have different ways of producing that number. When we look around the world, it's pretty consistent that they say 1.2, 1.5. 1.0, somewhere in that range, but sometimes they're only including sporadic cases. And really, you're going to capture most of the cases if you're only looking at sporadic. Probably 85 to even 90% of cases are sporadic. So it wouldn't be that far off if you were only looking at that segment. But we do include the genetic, iatrogenic, all those cases when we come up with that number.
So that 1 to 2 per million per year is all cause prion disease.
Yes.
Great. We have a couple questions on this, and we get it every year, and that is whether or not families should go back and change death certificates. Say, for example, the family member that asked this question, their loved one had been diagnosed with cortical basal degeneration, which is not a prion disease, but on autopsy was found to have CJD. Do families have to go back and do that? And will you know of any changes if they make those requests?
Yeah, that's a good question. And do they have to go back and make the change? It's really more of a personal decision. Some people want to just because they want that level of accuracy. They want it for their family. They want it just, so their grandson has that record, whatever their reason might be, they do that. But is it a necessity? No. And in fact, that's one reason why I discuss our matching process during my presentation, because we work so closely with the National Prion Disease Pathology Surveillance Center. We have access to that wonderful database of their specimen results from their testing. And so if the autopsy was performed at the Prion Center and it was positive for prion disease, we are aware of that particular case, and we have made a note of it, and that's included in those incidence figures that I've shared. So just because the death certificate doesn't say it, doesn't mean we don't know about it, because we have access to that wonderful source of data. And so, do you have to go through all those channels? No. In some states, it's probably easier than others. But it's really more of a personal decision. Yeah.
So I guess what you're saying is from an epidemiology standpoint, it's not necessary. But of course, there's other reasons why people may want to change it, just for accuracy's sake,
Sure.
Closure and whatnot. So this is a really good question that I think a lot about. And that is with COVID-19 and its response and closing a lot of services. Could that potentially affect the ascertainment or detection of prion disease in the year 2020?
It's going to be interesting. And part of this question, you may be able to answer better than me, Brian, if you can maybe touch on what you've seen at the Prion Center in terms of specimens. But just from where I stand, we've looked at some other diseases, and it seems like for the most part, the more serious diseases have still been reasonably accurately tracked during 2020. Things where someone didn't have to go to the hospital or didn't have to receive care. Certainly there was some delay in them receiving that care, pushing it down the road a bit. But for the more serious afflictions, it seems like there hasn't been that sharp decline in people being treated. And when we talk about a disease like CJD that is so dramatic, I think that there would be a lot of people seeking care as a result of that onset. So our death certificate data runs a couple years behind. I mentioned during my talk 2019 data several times, and you may have been thinking it's 2021. You know, what are you talking about? So we haven't seen what's going on in 2020 yet. We hope to receive that data soon, and it'll be interesting to see if there is any kind of decline. But my guess is that hopefully it won't be a sharp decline, and that we will continue to have good surveillance over that period.
Yeah, I guess a personal experience as a clinician, there was about a month and a half to 2 month time period where I couldn't get an MRI or a spinal tap or even an EEG on a patient. And of course, these are kind of necessary tests, right, for these illnesses. So that definitely inhibited my ability to properly work up patients. From the surveillance center standpoint, there was a very sharp decline in those 2 months. Almost half the number of samples that we generally receive. And we didn't see a reciprocal rebound, meaning that, the following months overcompensated for the number of specimens that it was reduced by the prior months. So that's a concern. Our total number of RT quick cases was lower in 2020. So I think, the death certificate data is going to be really helpful for 2020 and be able to see that. Because as you say, most serious diseases were addressed. I think mainly we're talking about acute diseases, things that happen like that, like a heart attack, right, or a stroke. You're gonna get medical attention. But the problem with prion diseases, they're kind of subacute, right? They're quick, but they're not usually an emergency within a day. And with the average duration of 4 to 6 months and a delay of 2 month time frame, that's a half to a third of someone's duration. So I'll be interested to see what the death certificate data demonstrate for that year. I think it probably will help tell the whole story. So.
Yes, and it'll be interesting to compare it, not just by itself, but to compare it to 2019, where I'm hopeful that we're going to have an increase in accuracy. We may see a decrease in death certificate accuracy during 2020 that will hopefully rebound this year and next. But certainly, if there is a gap in there where the tests just weren't being performed, that is going to affect the diagnoses, unfortunately.
And this goes for other diseases too, like chronic viral meningitis and whatnot. I mean, who knows? It could affect a variety of different illnesses, and I'm sure a lot of people will be studying that for years to come.
Yeah.
The next question I had kind of harkens back to the COVID-19 question. So it's difficult, I think, as a loved one to understand why their family member developed such a rare disease when they're healthy. So a lot of times family members will look for potential triggers of the disease. So of course, COVID-19, people thought that could be a potential trigger, but have you demonstrated any other potential triggers of CJD, whether it be traumatic brain injuries, surgeries, psychological trauma? What's your take on that?
It's an interesting thought, and it's not something that I've investigated directly, or our group at CDC has really taken a close look at. I have heard a couple of presentations on the topic. Some of them have focused on genetic forms of prion disease, seeing if there is a link. Why is the later generation coming down with the disease earlier than the previous generation, for example, with a genetic mutation? Is it because they had knowledge of the disease and it somehow caused a trauma that in turn led to earlier onset of the disease? And there's been some studies that have looked at things like a car accident and whether that could somehow precipitate or start the onset of the disease process. And it's hard to nail that down. Much like I said earlier with coincidences happening, you have to be able to split out where that line is. People that have been through something as horrible as seeing a loved one diagnosed with a prion disease might be more likely to recall a recent traumatic situation than someone that hasn't been through that, for example. So these are the kind of questions that have to be looked at in greater detail to really have a good answer to that question. And then I don't have a good answer.
The other thing that might be useful to touch upon, Brian, is the concept of incubation period. So when we were talking about COVID-19 earlier, you had said, well, biologically, there's no plausibility for that, right? And I think a lot of the times people in our shoes, we think, well, you just don't see prion disease after a couple of days exposure, right, to something. So could you talk a little bit about that, what we've learned in the field about incubation periods?
Yeah, no, that's a great point. These diseases are characterized by those long incubation periods. You take a disease like bovine spongiform encephalopathy, for example, and you don't eat meat from a contaminated cow and come down with symptoms a week later. It's, 8, 9, 10, 11, 12 years later. There's been a few instances of the disease being transmitted through neurosurgical equipment. That can be a year or more. There's a case in the literature of CJD being spread through a corneal transplant. It was actually over 30 years. Human growth hormone also very characteristically can have multiple decades from the time of exposure to the time of disease onset. So certainly these incubation periods are things that are measured in years, not days, weeks, or months. And so we definitely have to keep that in mind when we talk about this new disease, COVID, that just came around recently. Would it be linked to something like this? Biologically, probably not, given the fact that these are diseases that are characterized by these long incubation periods.
Great. Another question that we had actually was from a longtime board member of the foundation, Marie Kasai. Hi, Marie and Bob. I'm glad that you guys are listening. We miss you. And I'm assuming her question is, she wants to know whether or not you need to prove that a family member died of sporadic CJD if you wanted to, I'm assuming, donate blood or organ. And what's the burden of proof there?
Right. And it's a little bit murky, in my opinion, because it seems like the FDA guidance is kind of in a don't ask, don't tell mode with that particular guidance. If you just go in and they don't ask the question, I don't think. I don't think they're going to say, did you have a family member that had CJD? I think their new guidance doesn't have them really asking that question. So if you tell them that your family member had genetic CJD, you would be deferred. If you don't bring it up, then they don't bring it up and you just proceed. That's kind of my understanding of it. And again, different donation centers may handle that a little differently. Let me pull up the exact guidance here. Yeah, so the guidance says no longer recommends questioning donors regarding blood relatives with genetic CJD. So they're not really saying to even bother asking the question. So that should help a little bit in that regard.
Yeah, it is a little bit confusing, I have to admit, but I think you're right. It's almost as if it's a don't ask, don't tell. It kind of leaves a lot of it up to the family member themselves, actually, to volunteer or not. You had mentioned sorry,
issue has come up. I'm glad. I know this was a question that came up a lot in previous years about people who know that their grandfather had sporadic CJD and not being able to donate, even though there was no mutation present, and in the frustration that they were feeling. So I'm glad that the FDA guidance is, attempted to address that issue.
Yeah, definitely. I know families appreciate it as well. You had mentioned a little bit earlier, when we were talking about variant CJD, that kind due to eating meat contaminated with mad cow disease, that potentially military personnel were exposed. So one of the listeners had a question of whether or not there's an increased incidence of prion disease in military personnel, whether it be from that exposure or another type of exposure.
Right. And so this is where we always have to make that distinction between variant CJD and classic CJD. And so variant CJD is what we believe is linked to the consumption of contaminated beef from cattle with bovine spongiform encephalopathy. So in this country, we've only had 4 cases of variant CJD. And as far as I know, none of those were military personnel. So they don't appear to have really been at an increased risk, or at least we haven't seen that in the few cases we've had in this country.
We have another listener whose family member unfortunately passed last month, and they wanted to know, how long does it take for their loved ones to be added to your numbers of CJD?
Yeah, that's a good question, and sorry for your loss. Always, a horrible situation, I'm sure. And then to answer your question, there's several different mechanisms that I mentioned in my presentation, but one of the main ones is our collaboration with the National Prion Disease Pathology Surveillance Center. As you know, they are constantly doing these analyses of specimens from people who have suffered from this disease. And so we access their database on a regular basis. Once a year is when I sit down and really do the matching process with the death certificate data. But, as far as us knowing about a case or having access to the information on that case, it's more or less as soon as the Prion Center puts out that final report, because we work closely with them. And so in that regard, if they saw something unusual in a particularly young case or with a unique exposure, we would know very quickly about that particular person.
And another COVID question. We talked about whether or not COVID and or the vaccine is associated with symptomatic prion disease. A common question we get, and I think it has to do with the novel nature of these vaccines being mRNA based, is whether or not it could affect someone who may have a mutation for genetic prion disease, whether or not they have to be concerned of it being a trigger.
Right. And just all cards on the table. I am not a COVID expert. And so, I can't speak to the mechanisms of how these new vaccines work, other than to say that based on what I've read, there's no reason for me to be concerned about that kind of thing happening. That's based on my reading of what's been put out about the mRNA vaccines. But I don't have a better answer than that. I can't really speak in great detail about that.
I think part of what I see happening is we have some generic terms in medicine, right? So protein is one. We see this a lot with CJD, where we know it's caused by a prion protein. So a lot of family members hear the word protein, and proteins make up a lot of things that you eat and that you consume, and could that have potentially been an exposure? So I think sometimes when people think of mRNA affecting genes, that again, because they have a potential for mutation for a genetic disease, that might be a correlation. But in fact, there's a lot of different mRNAs and DNA segments that really have nothing to do with prion disease. So I think that's partly what is going on. We had two questions about this, and that is there an association with dental implants and bone grafts with CJD?
I'm not aware of any association. There was some concern early on about certain grafts where the bone may have been derived from cattle. And the question was, could they have had bovine spongiform encephalopathy? I'm not aware of any cases that have come to fruition regarding that. I'm not aware of any cases of CJD in general that have been attributed to bone or dental work. The main routes of transmission that have been noted, I mentioned the human growth hormone, dura mater, cornea transplants, and in a few instances, neurosurgical equipment, EEG depth electrodes. We have concerns from time to time if a patient had something like a brain biopsy and the equipment was subsequently used on someone else, we'd consider that to be a risk. But again, I haven't heard of any cases where dental or bone or things like that have actually led to transmission of the disease.
Okay, great. Well, we're coming up towards the end of our time, and I apologize because there are a couple questions that we didn't get to, but I would encourage those individuals to contact the foundation, and they can try to connect you to the right person to get those questions answered. One of the themes that I'm at least trying to convey in this virtual conference myself is the theme of what have we learned in our field, and are there things to be optimistic about, or at least take pride in? And Ryan, you've been in this field a while. So from your standpoint, what do you think is some of the major accomplishments that we've seen since you've been in the field? And are there things that you're optimistic about going forward?
Yeah, that's a good question. And you're right, I have been doing this for a while. I'm back when I started, there was really a very rudimentary National Prion Disease Pathology Surveillance Center. And our collaboration with the center has come so far in terms of access to the data, in terms of the wonderful work the center is doing, the testing. I mean, the RT Quick is a game changer. There was nothing like that in the early 2000s that was that accurate, that could be done on a living patient. So that was one major thing. Another thing that's directly affected us has been the improvements in the death certificate data. When I first started, we didn't have access to the literal text. So in other words, we had to rely on the codes that were on the death certificate. Someone puts a code for anything that's written on there, but it's not always correct. And it obviously leads to a lot of questions. And what we started being able to do is see everything written on the death certificate, whether it's CJD or DCJ or Creutzfeldt-Jakob spilt all sorts of crazy ways, or prion disease or BSE or bovine, anything written on there, we now can pull and know that was the diagnosis. And so that has really helped us. And also working closely with the National Center for Health Statistics for that death certificate data, we now actually get the death certificate data faster than we used to. I know that I keep mentioning 2019, and that seems like so long ago, but we should have 2020 soon. And that is a marked improvement compared to when I first started, where there could be a 3-year or more delay in getting that data. So we have more accurate data, we have faster data, we have better diagnostics. All those things are great. And as far as looking to the future, I think the better diagnostics are going to lead to paving the way for better treatment options. And really the goal here, of course, is preventing these diseases or finding a treatment. And the first step in doing that is catching them early, before they even happen, ideally. And obviously an autopsy is too late if you're trying to stop the disease. So these improvements, I think, are really going to help out, and hopefully they'll continue. And just very excited about that. I know that Ionis, I don't know if they're giving a presentation this year, working on some exciting research with oligonucleotide technology and working on that. So I think the future is better. I think that we're moving in the right direction, and certainly in recent years, that progression seems to be faster.
Well, Ryan, thank you so much for taking time out of your day to give us this talk, and as always, very informative. And I'm sure the families join me in just thanking you for all the work that you and the CDC have done over the years for family members and for this country. And I really hope we can see each other again in the next CJD Foundation Family Conference. So thanks again.
Thank you. Thank you, everyone. Have a great night.